Hi, everyone, and welcome to the Otolaryngology Clinics podcast series. I'm Taylor Hayes, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the August 2025 issue dedicated to office-based otolaryngology. Here now is the consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
Hello, everyone. I'm Dr. Sujana Chandrasekhar, consulting editor of Otolaryngologic Clinics of North America. Today, I'm speaking with Dr. Ashley Agan and Dr. Robert Deeb, who are the guest editors of the August 2025 issue of Clinics, which is on office-based otolaryngology. Dr. Agan holds MD and MBA degrees and is the founder of her private practice, Scotty, in Dallas, Texas. Dr. Deeb is director of the Division of Facial Plastic and Reconstructive Surgery in the Department of Otolaryngology Head and Neck Surgery at Henry Ford Health in Detroit, Michigan. I met Ashley when we spoke on a panel at a national meeting on eustachian tube dysfunction, and she is co-lead of Backtable ENT, which provides wonderful podcasts about all things otolaryngologic. I encourage our listeners to subscribe and listen. I met Robert when he was a fellow at Mount Sinai in New York City, and we found out quickly that we share a similar sense of humor, which might be unfortunate for our friends. Dr. Agan and Deeb have a great deal of experience in moving ENT procedures from the operating room to the office and have put together a comprehensive issue of Otolaryngologic Clinics of North America that addresses just about every question one could have on office-based otolaryngology. You can get this issue and all clinics issues and articles at www.oto.theclinics.com or in your institutional library or maybe even in your personal library. And you can listen to all of our podcasts, which is one per issue and special article series since 2017 at the website or wherever you get your podcasts. Welcome, Dr. Ashley Agan and Dr. Robert Deeb.
Hello. Thank you for the opportunity and for the time to do this today. I'm excited.
Yes, nice to see you. Thanks for having me.
I will alert our listeners that there is accompanying video content with many of these articles. That content can also be accessed at oto.theclinics.com when you purchase the issue or series. So, Ashley and Robert, let's move ahead and talk about this information-packed issue. First, I'm going to start with Ashley. So, Ashley, I have a number of questions for the novice thinking about moving procedures from a surgery center or a full operating room in a hospital, let's say, to their office. Why are they becoming more common in otolaryngology? When did this movement begin? Sort of over what period of time has this been happening? Do you think this is going to continue, or are people going to be moving back to more formal operating rooms? And is this providing better patient care, better doctor care? Why do this?
So the reasons are kind of twofold when you think about advantages for the patient and advantages for the surgeon. And the big overall themes are convenience, efficiencies, shorter recovery, more cost effective. And there's a lot of advantages. So breaking that down, when you think about convenience, let's just take the patient first. So when a patient is coming in for an office procedure, they're coming to a familiar place. They're coming back to your office where they've met you before. They're not arriving to a big hospital or a big surgery center where they're going to get there early and register and change into a gown and do all these things, right? Usually they don't have to fast. If they're not taking any sort of like anxiolytic or sedating medicine, they can drive themselves. And so it offers a lot of advantages from that standpoint, especially for people who just really want to avoid having a general anesthetic. On the doctor side of it, because again, you're staying in the comfort of your office, so there's more you can control. You're not driving across the street or across town to go to your surgery center. You have all of your familiar equipment, all of your familiar people. Some people, depending on what the procedure is, sometimes they will get a patient ready, go see an office visit, come back and do their office procedure, giving the patient time to get numbed and anesthetized. And then from the cost standpoint, all around, it's just less expensive because you're not utilizing the OR. An OR is just an expensive place to go. And I think that, this has really become popular over the last 15 years. With the spark being when balloon sinuplasty really started taking off, and I think a lot of surgeons got really good at numbing up the nose and realizing that if you take the time and get patients properly anesthetized, then they can tolerate a lot, from as far as just different nasal procedures. And I think that, as far as are we going to continue to see more move to the office? I think that always depends. In healthcare, you just never know what's going to happen because there's so many different forces at play. And if you think about the big driving factors as far as cost and payment, that can swing things different directions. So as long as because there is equipment costs when you move things to your office. When it's in the OR, you kind of show up and the equipment is there. When it's in your office now, you may be on the hook for some of those costs with buying equipment, buying disposables. So as long as those are going to be paid for, I could see that this being a persistent movement with more and more coming to the office. But that's always just, you never know what's going to happen. And as far as is it better? I think that it depends on the patient. And this theme will come up over and over again as we go through these chapters, but patient selection is a big piece of it. And for the right patient, it is better. And it can be a much better experience for the patient and the surgeon. But I think, as we'll talk about, you have to take some time to make sure that we're picking the right patient for the right procedure in the right place at the right time.
Thank you. I think you hit on a lot of the concerns of people who haven't yet made the transition or in the process of making the transition. So it is still a bit daunting to consider replacing all of the resources that you get in a sort of proper operating room setup and having that in your office. So Robert, knowing that then you're on the hook not just for purchasing or leasing the equipment, but making sure it's working, making sure, all the safety protocols are followed. What is the sort of basic equipment that you need to perform these kind of procedures? And I know you're in academic practice. Ashley is in private practice. Some people are in hybrid. So what system level challenges have you encountered trying to perform these procedures? And I think, some of it is the hospital does rely on us to bring cases to them, right? The anesthesiologists rely on us to be partners with them in the care of the patient. So I think there are some nuances that I would love to hear from you.
Yeah. So you're right. This can be a big undertaking for people who have not done it previously or maybe have limited training in more office-based procedures. And I think we got to look at this from a couple of standpoints. Number one, it takes time, and there is a build-up process both for the physician, for your staff, for your office, the physicality of your space. You're not going to go from doing very few procedures to doing the vast majority of your procedures overnight. So there are kind of several hurdles you have to go through, and that takes, frankly, years to get to a place where you're doing kind of high volume office-based procedures. One of the themes in terms of equipment that you'll hear over and over as we go through our chapters is safety, safety, safety. Right? We don't want to compromise a patient's safety just for convenience. And we all know, training in a surgical specialty, that the operating room is kind of the gold standard for safety. We have highly trained anesthesiologists, we have highly trained operating room staff, we have highly trained nurses. It's a very controlled environment. And when we move that to the office, we want to try and replicate as much of that as we can. So a lot of the equipment, kind of, I think of in like two categories. There's the equipment you need regardless of the procedure you're doing. Things like AEDs, things to do basic
So
life
AED
support.
means
Oh,
So
geez.
it's the basic life
The
support
defibrillator.
defibrillator, correct?
Yeah, the defibrillator. Oxygen, having it on hand in case a patient, starts to have issues with their oxygen saturation. Um, things like fire extinguishers. So really, regardless of the procedure you're doing, um, those are kind of things that most offices come equipped with, but you may need to kind of revisit those and make sure you're really prepared for kind of worst case scenarios because you are be doing things that are a little bit more invasive than you may be doing on a day-to-day basis if you're not doing procedures. So that's kind of the kind of safety piece of it. And then you have to really think about this kind of subspecialty or the different types of procedures you're going to be doing. Um, Otolaryngology, as we know, is a very, even though it's a subspecialty, it's a very broad subspecialty. And as our chapter goes through, you're going to see a lot of different procedures, and you have to ask yourself, how many of these am I comfortable doing? How many of these do I want to do? Because each of them comes with a lot of equipment and startup costs, and it really depends on what you're focusing on. But certainly, as we go through the chapters, you're going to see a lot of recurring themes as it relates to endoscopy equipment. So, equipment to look into the different spaces we work with. Certainly, things like towers, screens, recording equipment. Those are things that most ENT offices have. And then you could start to get into some higher cost things like lasers, more highly specialized equipment. So I think the biggest thing, if you're going to be going into this space, is ask yourself, what do you want to do? How do you want to focus? Start slow, build up, and make sure you have that safety piece in place, regardless of what you're going to do.
I will direct our listeners to the article that you included by Doctors Meyerhoff and Jahan Pawar that really talks about step by step implementing office-based procedures in large institutions. So with a bit of a safety net behind you, which I think is great. So Ashley, you are freestanding, beautiful space. I follow your Scotty posts all the time. Gorgeous space. I kind of want
Thank
to
you.
go to Dallas and get sick so I can
Yes,
come
come
see
on.
it.
Well, no, don't get sick. Just come down and visit. Come check it out.
But so when you're starting in a freestanding space without sort of a panic button where people can come and help you, um, and we're talking about safety because I think before we talk about effectiveness or execution, we really need to make sure that the patient is kept safe, and the physician and the staff are feeling safe doing what they're doing. So you need you talked about the right patient, the right procedure, the right equipment, the team. How do you train your team? How do you set it up so that the level of anxiety about doing something freestanding is diminished?
hmm And we so Scott Fortune wrote our article that is all about patient selection, safety, and preparedness for office procedures. And he and I actually, like, before this, we even knew that this was going to be that this book was going to exist. He and I were like talking about doing a podcast just because we've done so many podcasts talking about office procedures. And because I was moving out of academic practice and into solo practice, I was like, I need to kind of know, like, what do I need to have? And how do you prepare for the worst case scenario? And so we had been like talking about doing a podcast on this. And then when I found out that we were going to be doing this issue, I was like, oh, we have to have a chapter about all of this. So we did end up recording a podcast. It was episode 224, if listeners want to listen to that, because we talked about it for an hour, a solid hour, about safety. But the, you know, the kind of overall outline for that article is patient selection. And we'll go back to this over and over again. So you're going to look at the patient just like you would if you were going to the OR. You want to know if they're sick, if they're on anticoagulants, if like, are they healthy enough to do this in an outpatient setting where you don't have the hospital right there? Can they come off of their anticoagulants? He broke it down into airway bleeding and cardiovascular monitoring, kind of changed up the ABCs, but being prepared from an airway standpoint. So, like, if someone were to have an airway emergency, do you have what you need? As far as just like, can you give basic support, like, like, for example, like an ambu bag, creating some sort of crash cart, being able to control bleeding. So having, maybe a cautery machine, having packing, having some way to control bleeding, having suction. I think, I don't know. I feel like almost everyone has had a situation where they had a nosebleed or something, and they're in the office and they go to turn on the suction and it like doesn't work. And then now your nurse and everyone is troubleshooting the suction and opening the cabinet and something's not plugged in, and you're just, it's like, and it makes you just like to where like now every time you do anything, you're like double checking the suction. Like you have all these little quirks that you do to double check because you've been burned before. So, and then, cardiovascular monitoring. So having at minimum something like a pulse ox, the ability to check a blood pressure, having, an AED, like you said, Rob, like an, what does that stand for? Automatic external defibrillator, but basically where you can just put the pads on and it can monitor until help can arrive. And, from it, you mentioned, or your question about training a team, that piece of it is all about taking time to regularly do mock emergencies, essentially. Okay, everybody, like everybody who's involved with surgery or with procedures in the clinic, let's all get together. Today we're going to run through a scenario. What happens if if a patient is bleeding, if a patient is hypotensive, if they vasovagal, if they have anaphylaxis? All right, where do we know where everything is? Do we know where our crash cart is? Do we have our reversal agents? So some of these procedures, patients will take like a benzodiazepine or an opioid. So do you have Narcan and flumazenil in the office? And not only that, do you have a little cheat sheet that says how much you give the patient that's just pasted on the wall, so that in the moment you're not having to calculate what's the dose that I need to give them to help in this situation? And so, in this article, it kind of really walks through these just preparedness, like have these things available and be prepared for the worst case scenario.
Yeah, I think that's great advice. And I think, the corollary to that is when you deem that the patient is not a good candidate, that's not a failure on anybody's
Right.
part. That is a true patient safety issue. And sometimes I find that my medical assistant or the nurse actually has a better handle on the patient because they're sometimes more honest about their concerns and their reactions before the doctor walks in or after the doctor walks out. So I think that team approach and that saying, you know what, this is better done for you in a more controlled setting, makes a lot of sense. Both of you included, every article is outstanding in this issue, but you included a terrific article on anesthesia in office-based procedures by Dr. Daniel Lee, L.I., and Dr. Yan Lee, L.E.E., that with really great illustrations on effective nerve blocks, a really useful table, as you said, delineating the need to know about the local anesthetics. So I really do encourage our listeners to look at that article and kind of use that table, maybe have that printed out and stuck on your wall. And as you were saying, Ashley, like we have an allergist in our office, and we actually have one of those for if there's some reaction to when a patient's getting shots. We're all there to help, but it's not helpful if we don't know what to do. And in that moment, it's nice to have sort of a very easy cheat sheet available. So let's move on from selection and safety and preparation to distinct ENT procedures that can be done. So, Robert, Dr. Roya Azadarmaki has contributed the article on office-based otology. Can you give us the highlights of that?
Yeah, so she really oh, it's a she, I hope.
Yes,
Yeah.
it's Roya Azadi.
She.
I know her
Okay.
as Azadi, and she like
I
suddenly.
didn't review hers. Okay, so I'm hoping we can edit all this. I'll
Yeah.
start that again, okay?
Uh-huh.
Yeah, she really gives a nice overview of all of the pathologies that an otologist encounters in the office setting. And she breaks it up nicely into kind of audiologic processes, so things that are affecting hearing, things that are affecting the middle ear space. And then she talks about vestibular pathology. So the chapter starts out with a nice overview of the different pathologies that would be presenting to the office, giving kind of, differential diagnoses, background. So it kind of lays the groundwork for the types of pathologies that someone would be seeing in the office setting. And then the corollary is to then talk about some of the procedures that are done in the office setting to kind of diagnose those conditions, manage those conditions, um, and talks about how some of those things can be interlinked. So she has a great video in the article that talks about, or that shows the management and diagnosis of eustachian tube processes. She goes into some length about how the eustachian tube is like the bane of the ear provider. It tends to lead to many of these downstream issues. So really kind of honing in on that eustachian tube, doing really precise endoscopy of the nasopharynx, looking at the surrounding structures, looking at the outer lining, inner lining, fossa, nasopharynx, posterior nasal cavity, and goes through some detail as to what to be looking at when you're examining those areas. And then she talks a lot about all the different procedures that we do when managing the ear. I think it's one of those things we take for granted. We almost don't think of these as procedures sometime because it's just something we're doing as part of our examination. But certainly things like ear cleaning, mastoid debridements, placement of ear tubes, how to do these things in highly effective, efficient ways is really outlined. And then there's some of the more advanced procedures, things like transtympanic steroid injection to manage someone who has a sudden hearing loss. So it's a very nice, I'd say, comprehensive overview looking at different otologic conditions. And I do think our readers will get a lot of benefit from that.
Yeah, I agree. As an otologist, of course, this was my favorite article. So um, but I will give you a scary story just because scary things can happen with minimal intervention. So I was in my office, which is freestanding right by Rockefeller Center. So really, there's no healthcare facility nearby. And a lady came in, persistent serous otitis media, and she sort of had this yellowish, kind of dullish fluid in the middle ear. And very fortunately, because sometimes the right thing happens despite me, I did a myringotomy with just a 25 gauge spinal needle. So I said, oh, I'll just extract some of this fluid. I'll make her hear. She'll be fine. My nurses, because I'm looking at the needle through the microscope and I'm extracting fluid, and it's like a lot is coming into my syringe, which is only like a 1 cc syringe. And my nurse's eyes out of the corner of my eye are getting huge because I had decided to put that needle in her dehiscent carotid artery. And my syringe was full of really beautifully oxygenated carotid blood.
Wow.
And I was like, oh gosh. And it turns out if you do that with a 25 gauge needle, put a little bit of pressure, you don't panic, you can stop that bleeding, but you really should not do that with a myringotomy blade. And I'm pretty old and I've been around the ear for, a few decades at this point. So weird things can happen all the time. So again, just taking it sequentially, having a nurse who had been with me forever, who knew not to panic, who knew to get me what I needed to get, right? Really important. Patient did fine. I eventually did fine. I think my nurse eventually did fine.
I'm sweating. I'm like,
I'm also shaking over here. I know, I don't know, we're not supposed to ask questions, but I have to ask.
Uh-huh.
Where were you in your career when you did that? Sounds like you had already had a lot of experience. And more so, did it affect you moving forward? Because I do worry about and I think, Ashley, you were talking about this. If you take this leap to start these office procedures and you have something go badly or maybe not go as, I think that affects us. And you can, I've seen colleagues start to say, I don't do that in the office anymore. Like, it's not worth it. I'm not going to, I'm not going to fight through. I remember the fear I had, and I'm not going to do that again. So can you speak to that a little bit? Because I think that's a real thing we experience.
Yes, I totally agree. I think when something goes wrong, that imposter comes out right away, and we right away feel like, oh my God, this is something I never should have done, et cetera, et cetera. It happened last year, so I was quite serious, quite far along in my career, and uh, I've been very good over the years at learning how to breathe when things go awry, because things go awry when you do any procedure anywhere. Um, I think I was very grateful that I was using that small needle, and I think that's something I would recommend to people to just if you're tackling just the common serous otitis media within myringgotomy, I would use a needle as opposed to a blade. And then if it's mucoid, then you can always convert that to a larger opening with the same, I use a phenol anesthetic, so it's easy. Um, I got her a CAT scan, uh, took her to the OR for her balloon dilatation and her tube, and made sure that I was super safe. Um, but I think it can change you, and I think it can make you stop doing something for the wrong reason.
Yeah.
I think there are things that you should stop doing for the right reason, but sometimes this is the wrong reason. And I think it's really a matter of like taking a beat, making sure the patient's okay, making sure you're okay, going back, looking at the literature, talking to some of your friends, with that level of experience, and saying, okay, what should I do now? What's the correct step? And I think it's a great question, Robert. And I like you said, we're all kind of shaking thinking about it, right? You don't go into work thinking I'm going to go hurt somebody today, right? So I think just being very deliberate in your thought process is what helps when things go awry. Now, I will tell you guys, because the ear is kind of a scary place sometimes. The very first time I elevated a tympanomeatal flap and got into the jugular bulb, I was a resident. My attending was my father. I have inherited my mercurial personality from my mother. He is calm as can be. The whole thing fills up with blood. And I'm like, of course, I was me. So I was like, oh my God. And he's like, Sudge, what do you think is going on? I'm like, what do you mean what's going on? It's full of blood. And he's like, well, you could elevate the head of the bed. And I mean, it was like we were having a stroll in the park. And it sort of taught me that bring the temperature down, and you can take care of the problem. Because we actually all know how to take care of many of the problems that can arise. So there you go. We're going to be done with otology because it's really not as scary as I painted.
Well, I think the really informative part of that is when you mention support staff.
Yes.
Like, I don't think we should be shouldering all of the load of these procedures. And in fact, I have had times now where I say, you know what, my staff, because we have turnover, I'm in an academic setting, I'm going to stop doing that for a little while until my staff gets a little more trained up and I become comfortable, because it so much depends on the people you have around you, especially in recognizing things that may be going wrong. So that's a great example of that.
Yeah. Yeah, I agree. So, Dr. Azadi talked about in her chapter balloon dilatation of the eustachian tube. And Ashley, when we sat on that panel, I was like, who is this magical girl? What is happening here? You really impressed me. I wrote it down. It's in my little index card of Ashley's technique is still there. So you really impressed me with the safe and effective balloon dilatation of the eustachian tube in the office. And then you and Dr. Nora Perkins contributed a really thorough article on this to this issue. So can you give us your little elevator pitch of like how to for this?
Yes, and I'll try to contain myself because I could talk about, I get excited and I could just talk about this. Like I don't know how tall our building is with this elevator, or if we're on a fast like how many floors we're in. but I love balloon dilation of the eustachian tube in the office because it's such a quick procedure. I mean, you're dilating for 1 to 2 minutes and then it's done. And so sometimes patients still want to go to the OR and that's fine. But when we do it in the OR, everybody, gets everything set up and anesthesia gets all set up. And then I come in and I'm like, okay, I'm done. And so everyone's like, oh, because it takes longer to get everybody situated in the OR than the procedure does. So the office is great because it is such a quick procedure. But you still want to have, the right patient, meaning like when I'm examining them, like I'm already kind of noticing how are they doing, with just a nasal exam? How are they doing with the scope in the nose? Do they seem really nervous? Are they really jumpy? I will also usually also ask them if they've ever had issues doing a dental procedure, if they have been told that they had a hard time getting them properly anesthetized. If anybody says anything like that, like, oh yeah, they told me they had to, really had a hard time getting my numbed up for my, tooth removal, then I'm like, that's like kind of a red flag. When you start out, you want to pick an easy nose, just nice straight septum, lots of space. You want to be able to just kind of, because you're working in the back of the nose. And so you want to be able to just kind of go straight through as you get used to it. And in my hands now, like if there is a little bit of a septal spur, a lot of times I can work around it. You can outfracture the inferior turbinate. It's not an absolute contraindication, but in the beginning, just pick an easy nose. I think we spent a lot of time in this chapter talking about patient selection as it relates to diagnosing dilatory obstructive eustachian tube dysfunction and ruling out patulous, because you never want to dilate a patulous eustachian tube. And so we did spend quite a bit of time just talking about, you need to look at the eustachian tube. You can't assume that just because a patient has a type C tympanogram that they've got an obstructive type of eustachian tube disorder. And you want to be asking, do you ever experience autophony? I will frequently have them do a modified Valsalva, a Toynbee, ipsilateral nasal breathing, all of this while I'm looking in their ear with a scope and recording it and seeing how the eardrum moves as they do those maneuvers. And so for a patient who has true obstructive type pathology where they have trouble moving air across the eustachian tube, you'll see little to no movement of the eardrum, or it'll be really hard for them to lateralize the drum, and when they do, the air will kind of get stuck there and it doesn't come out easily. They're kind of hyperinflated for a moment. And so picking the right patient is really important. Personally, I feel like the Barrow Challenge patients do really great with a balloon. Those patients who have a type A temp, they're pretty normal when they're on the ground, but if they try to fly or if they're trying to get their scuba certification and they just can't equalize, I feel like those patients tend to do really well with the balloon dilation. Nora and I both like to encourage a little bit of oral sedation if patients have a driver. And so I typically will do some triazolam, which is a benzodiazepine, promethazine, and tramadol. And I just do that combination because it tends to make patients comfortable, but not like zonked, like they're relaxed, but they're not like asleep. They can still walk into the office and walk out. I will also have them do a little bit of oxymetazoline about like when they wake up that morning and about an hour before, just because I want the nose to be like really maximally decongested, and so that I have that nice straight shot back. I numb up the nose. There's lots of different preparations for numbing up the nose. I like a 4% lidocaine, 4% tetracaine jelly that I put in the nose on pledgets for about 10 minutes. I also like to inject. So I will inject the sphenopalatine region, and I also inject the torus at about 12 o'clock. If they have a deviated septum or spurs that my scope and instruments are going to be bumping up against, I might inject those too. Some people don't inject at all. It just, there's lots of different ways to do it, but you just want to make sure that the patient's not jumping around and feeling anything as you're moving the instruments in and out of their nose. And then we have lots of different options for devices now with the balloons. They come in two main categories. in one category, there is a guide, and the balloon comes out of that guide and slides into the eustachian tube. The other is a rail with where the balloon, the rail itself is rigid. It slides into the eustachian tube, and the balloon slides over that rail. So those are the two main styles that we have. I think it's really important to have a 30-degree scope. I know some people don't feel like it's necessary, but I think with a 30-degree scope, you can really see up into the lumen of the eustachian tube, and you can kind of see where your instrument is going, because you don't want to create a false passage. It's the last thing you want to do. And when I am guiding that balloon in there, just go. I'm telling myself, just go slow to go fast. So when I'm inserting it, I insert it nice and slowly. When I'm inflating it, I inflate it nice and slowly. And then I do 1 to 2 minutes based on the amount of inflammation I see. And then you deflate it and you take it out, and then do the other side, or if that's indicated. But it's a great procedure. It's really effective for the right patient. It's great to be able to offer in the office.
And I think in your article, you and Nora included really great video content, boxes, tables, a flow chart. So there's a lot. If you're thinking about making that leap for this procedure, I think this is a really great how-to. So I'm Dr. Sujana Chandrasekhar. I'm consulting editor of Otolaryngologic Clinics of North America. I'm speaking with the guest editors of the August 2025 issue, which is on office-based otolaryngology. The guest editors are Dr. Ashley Agan from Dallas, Texas, and Dr. Robert Deeb from Detroit, Michigan. You can find this and all issues of clinics online at www.oto.theclinics.com or in your institutional or hopefully personal library. We have recorded a podcast per issue and special article series since 2017. And it's really been fun interviewing the various guest editors for me. Please do give them a listen. So let's get back to office-based otolaryngology with Doctors Ashley Agan and Robert Deeb. So Robert, facial plastic and aesthetic procedures often lend themselves well to office-based care in a number of ways. This can be economically and time-wise advantageous for the patient. As we talked about in the safety portion, it doesn't take away their whole day and add anxiety for them. So you have 2 articles in this issue on facial plastics topics. One is on non-surgical facial aesthetic procedures by Doctors Mubayed, Desroche, and Dean, and one on facial plastic surgical techniques by Dr. Donaldson and you. And of course, there are really wonderful pictures in these articles. So let's start with the aesthetics article. I think there were a lot of interesting clinic care points that they included. Can you talk about them?
Yeah, I think, as you alluded to, facial plastic surgery as a subspecialty has probably, in some ways, the longest history of doing things in the office space. And I think there are several reasons for that. You have alignment of patient goals and surgeon goals, right? Patients want everyone wants minimal downtime, minimal recovery, back to life, and they want to look like they didn't have anything done if possible. And as a surgeon, there's a lot of upside to doing things in the office. Again, we've talked about this a little bit, but you're controlling the environment, you're controlling the space. You can create, a whole experience for the patient without a lot of the downside that comes from going to the hospital. So I think there's a reason that facial plastic surgery has been naturally drawn to the office space. And also, it's largely low tech. I want to mention that because, of all of our subspecialties within otolaryngology, we're not really using scopes and towers and television screens. And it's a lot of just good old fashioned, simple surgical equipment and relatively low cost interventions. So, we always think about facial plastic and reconstructive surgery, both as aesthetic procedures and reconstructive procedures. I wanted to include an article on both of those. So we have this great article that talks about all of the non-surgical interventions that I think some will be very familiar to our readership that have been going on for years and years. We're all familiar with things like botulinum toxin to treat wrinkles. That's been done in the office space for, many years. There's a whole laundry list now of dermal fillers with new ones coming out all the time to treat um, different aesthetic concerns in the face, to add some volume to some areas that have lost volume over the years. So there's a lot of interest in dermal fillers as well. And then there are kind of some newer players, in this space. Things like biostimulators, PRP, basically taking a patient's blood, extracting the parts that we know stimulate growth, that stimulate in some cases inflammation, which can then help to rejuvenate and restore different parts of, say, the hairline, areas around the eyes, area around the cheek, and down into the neck as well. Um, there are lots of kind of non-surgical treatments for, treatments of facial laxity. Things like facial threads can be used in the office space. Things like radio frequency microneedling can be done. These are things that can be used in select patients. And what's nice about the article is they speak quite a bit about who is a good patient for this intervention, what are their expectations, what are their concerns. A patient who has significant laxity, significant concerns with volumization is probably not going to do well with some of these, but we're treating a whole spectrum of patients in our facial plastic surgery practice. Certainly the trend in recent years is towards younger patients coming in, almost doing things like prejuvenation. Is there something I can do before things have gotten so bad that I need surgery? And I think the chapter really outlines some of those kind of decision making points where who's a good patient for this intervention, who's going to get a good outcome versus someone who probably needs something maybe a little bit more invasive.
And then I know you and I have talked about this in the past, and I know one of our issues of clinics was on the ethnically sensitive rhinoplasty. So I
Yeah.
think different types of skin respond differently. So I'm just gonna just ask you, just for general knowledge, like I happen to have, I'm Indian, so I have a different color and texture of my skin than Ashley, who's more Caucasian. So what do you recommend as you for different types of, like, let's say, the pigmentation problems that happen as we get older?
Yeah. Yeah. So that's a great point, by the way, because we talk a lot about these interventions. And the one thing you don't want, especially when you're doing something that's largely elective, is a complication or drawing someone's eye to a problem that wasn't there previously. So now you've fixed something, but you've maybe actually created something that's somewhat worse. And we talk about that a lot with incision placement. Um, so when we're making, incisions on the face, patients that have thicker sebaceous skin, maybe darker skin types, that incision can become more apparent with time. We know certain patients, our African American patients, are more predisposed to things like keloiding, hypertrophic scarring. So it's really a conversation you need to have with your patient and really talk about, yes, we can make this better, but I'm not sure the trade-off is worth it. Also, when we're doing laser procedures, so laser resurfacing of the skin, treatment of kind of sun-damaged brown spots, telangiectasias, in patients with darker skin types, really you have to be very careful. And I would argue maybe to avoid certain lasers in certain patients because the risk of hypopigmentation is just probably not worth any benefit you might be getting from the underlying intervention. So having that conversation with the patient and really laying out what kind of the risk and benefit is, I think is so important.
Yeah, I think that's really crucial. I excused my spots on my face by saying that I always wanted to be like Pippi Longstocking, and now I've got the freckles to to show it. So I'm like, well, this was my dream when I was a girl. Moving from sort of the more aesthetic, and I really like that outline very much, to more of the cutting. So in your article, you talk about blepharoplasty, facelift, neck lift, lip lift, and then reconstruction of pretty significant defects that are, either after Mohs surgery or after some other kind of excision, usually of a cancer. Um, let's talk about how you do that in the office. And is this a situation where your friendly anesthesiologist comes to the office to provide support, or is this something that you can do without additional that level personnel?
Yeah, that's a great question, because we talk a lot about office-based procedures, but what we really need to talk about is how are you achieving that procedure, and how are you making the patient comfortable? So you could have anesthesia in the office. I mean, I don't do it at my institution. It's just not something from a regulatory standpoint that we're able to do. But there is straight up anesthesia, either IV or beyond, that's just done in the office setting. And to me, that is very much akin to the operating room. In my case, I'm doing these procedures really basically under straight local anesthesia, with perhaps a little bit of PO, anxiolytic medication, plus or minus some opioids. Very small doses of those, just to put the patient at ease, get a little bit of pain management under control. But as we outline in our anesthetics chapter, we can really create large areas of anesthesia on the face with underlying knowledge of the neuroanatomy. So certainly we're using lots of injectable anesthetic, and we're really assessing for patient comfort. Is this someone who could sit still for 1, 2, 3 hours, endure a fair amount of discomfort, both by sitting still and also the different injections? What is their level of anxiety? They may have claustrophobia, because we also have to remember we're creating a sterile field when we're doing these larger procedures. So they may be sitting in a dark, maybe not well ventilated space for an extended period of time. And to me, that's just a discussion you need to have with the patient beforehand. We're sometimes moving a lot of tissue around. So the patient, despite being well anesthetized, is going to feel something. They're going to feel pulling, tugging. They're going to hear something. They're going to hear, number one, us talking. They're going to hear, or they're going to maybe smell burning when we're doing cautery to kind of control bleeding. And sometimes you can get into different scenarios that may require more interventions. Again, we talked a little bit about controlling bleeding. So these can be larger procedures. And I think the biggest thing is, what is your comfort if you get into a problem, similar to what you discussed when you got into the dehiscent carotid?
You're gonna never look at me the same at any meeting anymore.
I love that it happened. I love that it happened recently to keep you on your toes.
Yeah.
But we've all
never get comfortable.
Yes, or too comfortable. So yeah, I mean, I think your comfort in managing what may happen as you're moving these tissues around is very important. And then the patient's comfort. We're working around the eyes. We're right up in their face with instruments. They hear us, they see us, they feel us, they breathe us. So a lot of it is upstream of that. Once you have a good patient and you have good anesthesia, you could do a lot. I mean, if we're just being honest, you can do a lot. You can do facelifts, you can do eyelid surgery, you can do cervical facial rotation flaps, you could do big skin grafts. It takes time. I think you have to This is not something you're doing like in between patients or running back and forth. You're probably, allowing a full day, a half day to be really at least I am, to dedicate some time, energy, mind space to this patient. These are not things you want to rush through. You want to give yourself time to do nice closures. The same level of result that you get in the operating room, you have to be able to create that in the office setting. You do not want to compromise the patient's outcome. But I do think with some time and experience, start up slow. Start with earlobe repairs. Start with little things more peripheral in the neck, lower part of the face, before you work up to say something around the eyes like blepharoplasty or something more invasive like a facelift. But it can be done. It just takes some time and knowledge of what your skill set is and what the patient can tolerate.
Yeah, and I think the other thing I would say, looking through this article, there's a lot of V, Y flaps, there's a lot of rotation. Until you are good at this in the operating room with the patient asleep, so that's the other piece of it. You need to be really good
Yes.
when everything else is controlled. Then you can take those skill sets and do it in a less perfectly controlled environment. Whereas you said the patient's breathing, you're breathing, everybody's breathing, everybody, there's stuff happening. So I think perfecting in the operating room with, we're all educators, so perfecting with your professors, and having them sort of give you the, hey, you did a great job today a few times, and then feeling like you can do that for yourself is really important before you start jumping into things where if the patient moves, if your assistant, as you said, Robert, is relatively new and doesn't quite understand what a hook looks like or whatever, right? You need to be able to compensate for that without worrying about your technique.
Yeah.
So Ashley, we're back to ears, yay. So doing ear tubes in adults is really quite straightforward. Unless the carotid is in the way, you're good.
Yeah.
You're good. And really older kids, as long as they can sit still, I find that they're quite easy to do. But let's talk about young children. So there's a lot of concern by parents with young children of anesthesia for myringotomy in tubes, for long-term effects of the fear of going to an operating room, all the things you talked about, it going to that big building, answering the questions, changing into pajamas, whatever. So, can you tell us, like, what should be realistic for, and at what age for young children for ear tubes, which are, still remain the number one operation performed oh, at all?
hmm Yeah, super common. Yeah, so there we have a chapter by doctors Kayvon Sheriff and Sheila Kofer about in-office tympanostomy tube placement in children. And the evolution of this has really come because we have these single pass devices now. So one is called Hummingbird, one is called Tula, and then there's one called Solo Plus that is newer that I don't know as much about. But essentially, when we place tubes, we are making an incision in the tympanic membrane, and then we have another instrument that's placing the tube in. Sometimes we might push the back flange in with a Rosen. We're in and out of the ear canal. And this is essentially making the incision and placing the tube in a single pass. And so for younger kids, if you could have, seconds of stillness, then you could essentially kind of pop the tube in, almost like when you have like an ear piercing gun, because it pops it in there. And so this is really for, I would say, patients where parents are looking for an alternative to going to the operating room. It depends on the child's temperament and their ability to cooperate, their response to pain. It depends on the parents' motivation to avoid anesthesia, or if they really, like, I've had some parents where they don't like the idea of not being with their child during the procedure. Maybe they have just a bad experience or just stress of the medical system, but the thought of like turning their kid over to kind of disappear behind the doors to go have a procedure without them just doesn't sit well with them. There are some places where it's OR time is the limiting factor. And so maybe, it's going to take a few months to get on the OR schedule, whereas we could put tubes in, the next week or quicker if that was an option. And then there is cost saving. So back to that piece of it, when you're not using the operating room, it is less expensive. In this article, Dr. Kofer really outlines nicely the kind of workflow and the importance of the team. So we're kind of going back to the same themes with every article. You have to she has a nice picture of what her Mayo setup looks like with her equipment. For the hummingbird procedure, you're using phenol to anesthetize the eardrum, similar to how you would when you're doing tubes in the office with adults. With the Tula system, they have their own numbing system where the child will wear these little devices on the ear and it will numb it over about 10 minutes. But the age range, they're FDA approved down to 6 months. Really, most of the time when you start seeing kids for an ear tube consult, usually it's more common for it to start around a year or older. I would say personally, this is better for younger patients who are easily swaddled or papoosed, and you can hold them. Once they are 2 and 3 years old, they are really strong and wiggly. And so I think, but I have had, I do these in my office. I have had some patients who I was really nervous because I was like, oh my gosh, this child is going to be so strong and it's going to be impossible. And they were great. So that I do think that it is different kids have different temperaments, and I have a very long discussion with parents about patient selection and the risk that when you're doing it in the office, there may be a chance that we have to abort because it has to be done safely. So just like we said at the beginning, like safety is the most important thing. If it can't be done safely, then it needs to go to the OR regardless. But I think this chapter just does a really great job of kind of the overview of it, what to expect, how to kind of have your team, because you want to be able to do it quickly. And so you've got team members that can just hand you the device quickly so that you can keep your eyes on the tympanic membrane. And, when it goes well, it's done in 3 minutes. And the families are like, oh my gosh, this was so great. And, the child didn't have to fast, and they're in and out of your office in less than an hour. And it can be great. But I think having a good team and picking the right patients and family members is really key.
Yeah, and I think using distraction techniques has been very helpful for the children, whether it's an iPad or Alfred Ilareta at Sinai has been doing a lot, and other people have, regarding virtual reality goggles, just kind of chucking them on them and sort of displacing them from their current experience. So very interesting as we move forward. So, we talk about the riddle of the Sphinx, right? So very young childhood and very older adulthood seem to be very similar. So as young children are challenging, so are elderly individuals, and who they often present with voice and swallowing issues. They have some frailty. So Robert, what can be done safely and effectively by office-based otolaryngologists or office-based laryngologists? And we're talking about voice and swallow.
The short answer is a lot. I think of all of the subspecialties within otolaryngology, I think laryngology has maybe come the furthest in terms of what they're able to do in the office. And I don't know what the percentage is, but I would bet a majority of what they can do in the operating room can be done in the office setting. Now, it's a very highly technological space. There's a lot of need for very specialized equipment, as we all know, and I think in laryngology. But certainly, they've started to find more and more benefit for doing things in the office space. So in terms of specifics, voice and airway conditions. So older patients, voice tends to weaken with time. We could have some weakenings of the muscles that move the vocal cords to bring them into apposition, weakening of the vibratory forces. And there are a bunch of different techniques, for essentially injecting things into the vocal cords to augment them, create more volumization into that vocal cord, and really improve patients' voice. It can also be used because as we know, as the voice weakens, our protective mechanisms for preventing aspiration can be compromised. So augmenting the vocal cords is certainly going to help with things like aspiration. It could potentially help with management of secretions. And our article by Dr. Lamb, Buckmeyer, and Dr. Shaw includes quite a bit of video content, great diagrams looking at the different approaches to accomplishing these things. Because as we know, there are lots of different ways to skin a cat. So there are techniques that can be done kind of transcervically, right through the skin and the laryngeal framework. But then also we have the option to go through the nose, through the mouth, get to the larynx that way, and perform a lot of these same procedures. And I think being facile in both is going to serve you well, because as we know, you may be starting a procedure one way, encountering some difficulties, both either on the surgeon side or on the patient side, and the ability to say, hey, let's try to go through the mouth, or hey, let's see if we can do this through the neck and maybe achieve the same thing. So certainly injection laryngoplasty, and this is another really important point that is kind of intuitive, what we may not think about, is you're getting immediate feedback. When you put a patient to sleep in the operating room, but you're trying to help their voice, you kind of don't know what you've accomplished. But being able to treat the patient who's awake, who's phonating, and being able to really calibrate your injection and kind of getting the outcome you want in real time is very powerful. And I think that has been one of the drivers to move a lot of these procedures into the office setting. Plus, the technology has just gotten so much better. I mean, when we get into these high definition scopes, you can see really high magnification of the vocal cords, see where you're placing these different materials. Of course, there's lots of different materials, lots of different ways to inject them. But the idea is you're able to see in real time that you're creating a difference, and hear in real time that you're getting the outcome that you want. So certainly the augmentation laryngoplasty space has been huge. I think it will continues to expand. And then you have management of lesions on the vocal cords, right? Things that, lumps and bumps, as we say, areas of vascular malformations, and even some early, I'd say pre-malignant in situ type cancers are all being treated with different types of lasers. So we have a chapter on lasers by Dr. Schaff, Daly, and Chow. We also have a chapter on dysphagia by Dr. Suresh and Dar that go into some details about, again, different techniques, different treatment modalities of addressing these different growths that occur on the vocal cords. And again, the idea of having that high magnification, really seeing what you're doing, having the patient kind of participate. Again, we keep going back to patient selection. They have to be able to tolerate this, because this can be uncomfortable. They have a scope in their nose. They have things going on through their neck. So balancing all of that and being sure you're comfortable. But I think this space has really grown a lot in recent years.
Yeah, I totally agree. And I think almost counterintuitively, the more frail the patient, the better they do with office speech and swallow, voice and swallow procedures. Because I remember the old days where everybody went to the operating room and, they were really, really frail. And so we were putting them at more danger with the general anesthetic than with, as Ashley said, the 10-minute polypectomy or the 10-minute vocal cord injection. So I think, unlike the other indications we've talked about, if they are more frail, you may be more inclined to help their speech and swallow in the office rather than take them to the operating room. It's really, and I agree with you, what has happened, that sea change in laryngology is really very impressive. So as we sort of wrap up this incredible hour, thank you again so much. I want to go up into the nose for a bit because Ashley, when we started this, you said, "Oh, this really all started when we started doing balloon sinuplasty in the office. So I know that there's a really nice article about PNN, or posterior nasal nerve ablation, and I recommend our listeners check it out. It's by Doctors Wu, Takashima, and Ahmed, and they talk about different techniques for that: cryoablation, radiofrequency ablation, laser ablation. Um, this talk is not really about how to ablate the nerve, but how to approach the nose in a safe way in the office. So there's another article you included on nasal airway obstruction by Dr. Weeks that really talks about advantages and disadvantages and what can you do in the office. And then you included a nice article by Dr. Few and Patel um, talking about balloon sinuplasty, placing steroid eluting implants, again with the posterior nasal nerve, and then inferior turbinate reduction. And I think when I've talked to patients who've undergone any of these office-based nasal procedures, they're really pleased from all aspects. And so, can you touch on this? It's huge. I just
Yep.
opened a can of worms, and I'm like, here, go explain this can of worms.
So yeah, the big take home points are that because we have gotten really good at being able to anesthetize the nose, we have moved so many things that we do in the operating room to being able to do it in the office. And it serves patients because they have it's easier for them. They have less downtime. We can work them in quicker. We're not having to rely on an OR schedule. And there have been new devices that have come along that have also taken things that may have been more extensive in the OR and taken it down to a simple procedure where you don't even have incisions. So, for example, when you talk about posterior nasal nerve ablation, the alternative to that historically was a Vidian neurectomy, which had, a complication of dry eyes that was prohibitive for a lot of patients. But now you have these devices that are ablating those nerve branches without making an incision. So it's, and if you don't inject, which some physicians will only do topicals, it really is like a bloodless procedure. Like there's no needles, no scalpels. It's, you're just treating areas inside the nose. And then, with the articles that talk about nasal obstruction and things we can do from a sinus surgery standpoint, again, the foundation is get the nose anesthetized, screen for patients that might have tricky anatomy. And so sometimes, for example, if they have a severely deviated nasal septum that's really pinching in on the middle meatus and you can't reach the area where you're trying to treat when you're doing a PNN ablation, maybe that's not the right patient. And to your point earlier, you want to be at a point in your surgical career where you've gotten really good at doing these things in the OR. So there are people who like Dr. Brian Weeks who are doing endoscopic septoplasty in the office because you can effectively anesthetize the patient and you can do it. You've gotten so good at it that you can do it, relatively quickly and straightforward and nice and clean. And so it's nice to be able to offer those to patients. With turbinate reduction, there's so many ways to reduce the turbinates and they all work. So you gotta just pick the one that you like, radiofrequency ablation, coblation, submucous resection with a microdebrider, just like we do it in the operating room. They all work great. And you mentioned virtual reality in the article by doctors Few and Patel. They also talked a little bit about using virtual reality to help patients, as it's like a non-pharmacologic anxiolytic to kind of help patients take themselves out of the anxiety of being under, doing in a procedure. So.
Yeah, I think the other advantage that I see is people who have either mild or moderate sleep apnea or sleep disordered breathing have to undergo like a million hoops to get this taken care of in the operating room. Whereas if you're doing it in a controlled and safe setting in the office, they can actually be helped with shockingly, less tension and like we said, this less controlled space. So it behooves thinking about things in much more detail. So the last couple of articles that I just want to touch on very briefly, still excellent. Thyroid nodules. So we're identifying them much more commonly than we ever did. And yet, people are not walking around with that pretty little scar at the bottom of their neck that they have to cover with a choker anymore. So, Robert, can you talk about uh, assessment and treatment of thyroid nodules in the office?
Yeah, I think this is another space that has changed a lot, really, in like the past decade. That, as you alluded to, we're discovering more thyroid nodules. We've also learned that surgery is really probably has been overdone in the past before we had this knowledge, and in many of these nodules is just not necessary. Um, the cornerstone to thyroid evaluation in the office setting is ultrasound. And I think previously that was something we would just ship off to radiologists, get this report, maybe look at some images that we didn't really understand what we were looking at, because as otolaryngologists, like, ultrasound was not a cornerstone of our training, like say CAT scan and MRI scanning and other imaging modalities. I think that has started to shift. And I think the people who are doing high volume thyroid surgery are becoming facile with office-based thyroid ultrasound. And I think that's full stop. I think if you want to be in this space and you want to be comfortable managing the full spectrum of thyroid and even parathyroid disorders, you need to be comfortable doing your own ultrasound. And really, I think there's a difference when we do our own imaging and read our own imaging, because we look at it differently than radiologists. We know the surgical landmarks. We know the different pitfalls that we may get into if we are going to go on and do a procedure, whether surgical procedure or office-based procedure. So really having a good handle on ultrasound, and the authors, Dr. Heichel and Dr. Goldenberg, talk quite a bit about ultrasound, what you're looking for when you're doing ultrasound, and then really does a little bit of a deeper dive at looking at management of these different thyroid nodules, specifically criteria that we're looking for and how we may manage these ultrasounds. New assays have come along, because if we're doing biopsies, now we're able to get more information about that nodule that we just didn't have before. There was a certain amount of uncertainty related to these nodules, and now we're able to hone in a little bit more on, really what's the likelihood of this being a cancer, and more specifically, like a bad cancer, which thankfully in the thyroid world is rare. And then they talk about radiofrequency, which I think is the new kid on the block. I don't know, 10 or 15 years now. We're right in the office. We're able to ablate these nodules and get a good volume reduction, which can both treat the underlying pathology once we have a biopsy, but also treat the patient's underlying symptoms if they're symptomatic from the nodule itself. So this is a space that's really moved a lot, I'd say, even since my training. And I think this is becoming more and more common in the office-based setting.
Yeah, and I would tell our listeners, you take the courses. There's a lot of really good courses offered with hands-on training for how to do the ultrasound, how to read the ultrasound, what to expect from those assays, and then how to do the radiofrequency ablation so that you're treating the patients correctly. I think they're always tacked on to the national meetings, at least in the United States, and it's worth the extra day to really go and think and learn. And then finally, it's really interesting. I feel I feel like Rip Van Winkle sometimes, except I haven't been asleep, I don't think. Um, and we went from removing submaxillary or submandibular glands for stones, trying to avoid the nerves that are there, trying to avoid some even some numbness in the area, doing things to the parotid, And we've gone from pretty sizable surgery for salivary gland issues to doing a lot of office-based sialoendoscopy. And I remember when sialoendoscopy started, that was an OR-based procedure. So the article by Dr. Ramadi gives details of how to do office-based salivary gland work. So Ashley, can you kind of give us the highlights?
Yeah, so this one is last, but certainly not least. I love this chapter. Dr. Ramadi, we also did a back table podcast, so a full hour kind of geeking out about this because I'm obsessed with soundoscopy. But he does a really amazing job kind of outlining, what types of stones would be good candidates for the office, what types of stenoses are good candidates to look at in the office. He is doing a lot of just at baseline diagnostic endoscopy in the office. So if they're a candidate to have an intervention, it can be done at the same time, but sometimes it's also just like getting a scope to kind of get a lay of the land and see what's going on. And so patients are able to almost in the way we do nasal endoscopy or flexible laryngoscopy when patients come in, it's able to offer a SAL endoscopy in the office, which is really awesome. He's got a great picture of his setup of his Mayo. He goes through equipment needed, what his exam room looks like. There's great pictures and a nice table kind of listing out the different instruments. He is in a big academic institution and also talks about how he developed that program there, including the billing aspect of it and how to make it so that it's a win-win for the patients and the surgeon and the institution. And so I think that's really important because I think that piece has probably been a hurdle for a lot of people because the equipment is expensive, it's delicate and breaks, and we don't have the codes are not quite the codes are not there yet. But I think that there are a lot of really great pearls in this, and for people who are interested in getting started, this is a really great place to start. And I will say the patients are looking for it because so many patients don't want to have a scar on their neck or to even accept the possible risks of having a injury to their marginal mandibular nerve. And when it works, when they are the right candidate and you can get that stone out for them without having a big surgery, it's a home run. They're so happy, and it's a really nice thing to be able to offer.
Great, thank you. Well, I'm Dr. Sujana Chandrasekhar. I'm a consulting editor for Otolaryngologic Clinics of North America, and today I've had the distinct pleasure of speaking with Dr. Ashley Agan and Dr. Robert Deeb, who are the guest editors of the August 2025 issue of Clinics, which is on office-based otolaryngology. Dr. Agan holds MD and MBA degrees and is the founder of her private practice, Scotty, in Dallas, Texas. She's also the co-lead of the excellent podcast Backtable ENT, which at the time of this recording has 265 episodes and is just growing by leaps and bounds. These are freely available and they are about all aspects of otolaryngology. I strongly urge you to take a listen. Dr. Deeb is director of the Division of Facial Plastic and Reconstructive Surgery in the Department of Otolaryngology Head and Neck Surgery at Henry Ford Health in Detroit, Michigan. You can get this issue and all Clinics issues and articles at www.oto.theclinics.com or in your institutional or hopefully personal library. And you can listen to every single podcast wherever you get your podcasts or at the website. So thank you so much, Ashley and Robert, for putting together this wonderful issue and for taking the time to talk with me today.
Thank you so much. This was so fun.
Yeah, this was a blast. I really enjoyed it. Thanks for having me.
Thank you for joining us for this edition of the Otolaryngologic Clinics podcast series. For an exclusive discount on the issue we discussed today, visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access or individual online-only access and is also available on Elsevier's electronic platforms Clinical Key and Science Direct. For more information on this series and our 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on LinkedIn, subscribe to the Otolaryngologic Clinics podcast wherever you get your podcasts, and leave us a review. See you next time.